So I am going to be talking this afternoon about TB reporting and referrals in LA County. So we've heard a lot about what's required for the USCIS technical instructions and also what the CDC recommends. And so now I'm going to bring it down to the local level, which is what we would require at the local TB control program for the civil surgeons to do. So just an overview of our county. In 2015, our estimated population was well over 10 million people. We are the #1 county in the U.S. in terms of size. And in the land area, which includes Santa Catalina and San Clemente Islands, is more than 4,000 square miles. We have 88 cities, as well as 140 unincorporated areas, and we're one of the 4 major immigrant ports of entry. So this is our challenge. We're dealing with a really large county, both in population as well as geographic size. I wanted to introduce you to how public services are arranged in LA County. Some of you may be aware that last year the Board of Supervisors approved the creation of a health agency. So this is at the very top, the health agency, and it's different departments are now under the health agency. This includes Department of Public Health, under which TB control resides, the Department of Health Services, which basically runs the county hospitals, and there are 2 other departments. The Department of Mental Health
If I could interrupt for a moment, I apologize. Yeah. There's been an issue with the recording, and so the AV is going to resolve that right now. I'm sorry for the interruption.
No problem.
Just take a moment. So for those of you that were not here first thing in the morning, just so that everyone is aware, this training is being recorded, and we do plan to make all or most of the training available after the fact. So you'll be getting an email about that in case you'd like to share the information with your colleagues. And you can continue. Sorry for the interruption.
So I was basically presenting the structure of the health agency. It's headed by Mitch Katz, and we have the Department of Public Health, Department of Health Services, and the Department of Mental Health, which I left off the slide because they don't specifically address TB services and needs. I think it's important to understand how we're structured so that when people say, oh, just go to public, you're going to get public services, they understand where your patients, so you understand where your patients are going and where they'll be receiving care. So the county hospitals and clinics are run by Department of Health Services. Department of Public Health runs the Communicable Disease Control Program, which is our program, TB control, and they also run Community Health Services. That is the clinical arm of public health. So they run all the public health centers and the clinics, and that's where patients go for immunizations and TB treatment, and where people don't have to pay for those services. And then we interface with private hospitals and private doctors because basically we monitor all the TB cases and suspects in the county. So to give you an overview of our TB control program, our mission is to prevent the transmission of TB within LA County through early detection and treatment of active disease and latent infection. And our vision is to eliminate TB from LA County. Our priorities are identify and treat active cases, which is something that we've been doing quite well, and identify and treat contacts to active cases to curtail outbreaks and prevent transmission. And this is where we want to really emphasize and increase our activities. And our products is targeted testing and treatment of high-risk populations. So this includes all the foreign-born from high endemic countries, people who have HIV, people who undergo specific medical treatments that put them at risk for developing TB. The kinds of services that we provide at TB Control, we're an administrative program. We conduct TB surveillance, means we keep track of every single TB patient, active patient, and TB suspect that gets reported to us. We generate the data and reports and analysis. We develop policy, provide education for patients, healthcare providers, and the community. And also the primary function is disease control and case management. So we oversee the contact investigations to make sure that there are no outbreaks. We find people who have active TB disease and who refuse treatment. We have public health investigators who will find them. We will issue legal orders, detain them, even put them in jail if we have to, if they have active disease, because they pose a public health threat. So this is mainly what the disease control and case management includes. It includes medical consultation for providers who don't see a lot of TB and might need some assistance in managing their patients. It includes discharge approvals from hospitals. So anybody who has active TB and is in the hospital, The physicians on the team are not allowed to discharge them without prior approval from TB control of the discharge plan. This is for us to ensure that the active TB patients are non-infectious before they get released to the community, and that they have appropriate follow-up and they get plugged in and don't just disappear in the community. We also oversee the clinical management of every single MDR or XDR TB patient. Similar to what Dr. Shah mentioned earlier, we have about 1 to 2% of our cases are MDR in LA County. So last year we had 6 MDR patients, and we had another 5 that were diagnosed elsewhere, but who came into LA County and we had to manage as well. And we had 1 XDR patient 2 years ago. We provide consultations for all the large and high-profile contact investigations, and we issue the legal orders that I mentioned. So basically for non-compliant patients, we can't force people to take medications, but we can detain them in a healthcare facility until they become non-infectious. So usually, you know, people want to go home, they want to get on with their lives, so they will eventually take treatment or accept some kind of management plan. Our county, the way the TB services are provided, so Community Health Services has 12 public health centers and 2 satellite clinics, and 10 of those health centers provide TB services. We have 3 county hospitals, LAC USC, which is our largest, Harbor UCLA, and Olive View Medical Center, which also has an inpatient TB unit. And we have 1 county jail where we also treat patients. So this is a map of LA County and how we're organized. We're divided into 8 service planning areas, 1, 2, 3, 4, 5, 6, 7, 8, as shown, and the stars represent where the health centers are located. So you probably can find the nearest health center that's closest to you, and that's probably where some of your uninsured patients would go to get services. Reporting, okay, so the basic 5 questions: why report, who has to report, when do you do it, how do you do it, and what happens when there's a delay or failure to report. So I'll start that with a case illustration. This is an actual real person. It's a 21-year-old man born in Turkey. He had a TST that was done as part of his immigration status adjustment paperwork process, and the TST was positive at 8 millimeters, or it was 8 millimeters, I should say. So he had a chest X-ray done as appropriate, right? Anything 5 and greater, they get a chest X-ray, and this one showed a patchy density in the right infrahilar region and right lower lobe. I don't have the film, unfortunately, so I can't show that to you. The radiologist determined that it could represent an early or mild right lower lobe infiltrate. So what next? Then the provider obtained a QFT, and it was negative. So how many people will report this patient? Okay, how many people would not report the patient? So I'll go through the slides and tell you the right answer at the end. I think it's also good to note that sometimes the radiologist may not say suggestive of TB disease or active. They may not mention TB at all. So it falls on us to sort of interpret the findings and figure out what to do next. So why do we have to report? Active TB is mandatory by state health and safety code. Those are the sections, lots of numbers, and also the California Code of Regulations. And the requirement is you have to report an active TB case or a TB suspect within 1 working day. All healthcare providers, basically, who interface with a patient who's suspected to have TB or who has active TB is supposed to report. And we also require that the directors of a lab who has a positive result suggestive of TB, they also have to report. So that tries to catch the report from various sources. When do you report? If you have signs and symptoms of TB, so you could have nothing else other than somebody coughing for 2 months with blood, that's a sign and symptom that makes you think, oh, this possibly is TB, the patient's from the Philippines, is a likely scenario, go ahead and report that patient. Or if you have an abnormal chest X-ray consistent with TB. Or if the patient is placed on 2 or more anti-TB drugs suggestive of active TB treatment, right? So for example, INH and rifampin, used to be used more frequently for the continuation phase of active TB treatment. But if somebody is on that, don't assume that we already know about the patient. You go ahead and report that patient. Because patients move from jurisdiction to jurisdiction, we may not actually have that patient in our records. And then when the lab would report is when they obtain a culture that's positive of TB, they'll report. If a sputum smear or a specimen smear is positive for AFB, they will also report. So this is what I was saying. And also the additional requirement is if you have a PCR test. So with the newer diagnostics, that includes nucleic acid amplification tests or PCRs. If those are positive, they also report. And then finally, when tissue pathology finds evidence of TB, such as AFB organisms, that's also required to report. And basically, if in doubt and you think you need to report and you're not sure, go ahead and call us. This is our general number. Somebody will guide you and tell you, oh, yeah, or oh, no, you don't need to report that person. So if in doubt, I would say go ahead and report or, give us a call. So what happens if there's a delay or failure to report? Well, it has contributed to serious consequences in the past in the sense that we can't initiate treatment quickly enough, so that person has exposed multiple people that he would not have exposed before that. And that means other people now have been infected, and now we have to convince those people to come in, take treatment, be evaluated, et cetera, right? And also, probably the most important thing is that it is a misdemeanor, and it is punishable by a fine or imprisonment. And it's also a citable offense under the California Business and Professions Code under unprofessional conduct. So going back to this patient, the patient should have been reported because he had a normal X-ray with a TST of greater than 5 millimeters. So this suggests that he might have a pneumonia. This could be an early presentation of TB. So again, kind of like what Dr. Naughton mentioned earlier today, because we're doing active screening in these patients, they're not coming with the severe symptoms that they might have developed if they've been, left unattended for months. So you may not see those cavities, the classic cavities, or the huge infiltrates. You might just see a mild infiltrate or something subtle, right? So yeah, go ahead and report. And then what do you do with the QFT that's negative? So with the presence of an abnormal chest X-ray and a positive TST, you have enough there to suspect TB. So go ahead and report. You can ignore that QFT. And in fact, probably I wouldn't even recommend checking at QFT in this particular patient because it kind of can confuse, the clinical picture a little bit. So how do you report? Dr. Naughton earlier did mention that I-693 has that section, that part 5, where you fill in all the information. You hand that to the patient. And the TB control program, we typically receive reports through the confidential morbidity report. And this is our website. You just can Google LA County TB control program, and then our website will pop up. And at the upper right-hand corner, there's a link, CMR, confidential morbidity report. That's where you click. And then it'll take you to a fillable PDF, and that's what that looks like. So you fill that out, you print it, and you can fax it to us, and that information, the fax number and everything is on the form, okay? So this is what we require locally for reports. If you happen to be like on the phone in the car driving and you are trying to, so this is the preferred form. You can also send in the I-693 if you want, although that's not something that we've been receiving. We generally receive this form. Or if in doubt and you talk to somebody, sometimes you can provide the information over the phone, but we still like to have the paperwork, the documentation. So how do you report? You can fax or mail the CMR. We prefer fax because it's quicker. Mail, it might take 5 days or whenever the post office delivers it. In the meantime, we have a TB patient out there, right? Or you can call us, right, to check. And then the lab will submit positive lab results to us directly to our headquarters. So what happens once you do that? So the reporting process, we receive all this information, we assess it, and then we will assign it and then forward it to the public health center, so the clinic, depending on the address of residence of the individual, right? Because we have those 10 health centers and we'll distribute it. And then the public health nurse supervisor receives, reviews, and looks at that form, and then will assign that patient to a public health nurse. So after that, the public health nurse then looks at the referral and prioritizes how quickly this patient needs to come in for an evaluation, and they will work in collaboration with the community workers and pharmacy and public health investigator, et cetera, to get this patient into the system and into the clinic to be evaluated. So that's what you can expect once you refer somebody. So what's new in TB reporting for us here in LA County? So as you know, we are working with Dr. Shin in the Partnership for TB Elimination, and we have started to collect some I-693 forms from select civil surgeons. So in the near future, you might receive a letter from our program requesting for you to submit the I-693s, and we'll request them regardless of whether the tests are positive or negative. And I know there's some concerns about possible privacy violations or HIPAA, but we do have health officer authority to request that information. And I think there's a letter that's been passed around. And if you can refer to that letter, it's basically from the California Department of Public Health. It's signed by Dr. James Watt, who's the chief of the Division of Communicable Disease Control. And basically, it explains that local health officers have broad authority under California Health and Safety Code to proactively investigate cases and take measures as may be necessary to prevent the occurrence of additional cases. So that includes trying to survey and understand the prevalence of latent TB infection in our county. And both HIPAA and CMIA, which is the California Confidentiality of Medical Information Act, allow healthcare providers to disclose confidential medical information to state and local health officials for purposes of preventing or controlling disease. So, you know, we are, it is under that kind of clause that is approved by the state. We've also had county council review that, and they also are in agreement with what the state puts forth. So eventually we will have a system set up where we will ask more of you guys to submit these forms and fax them to our TB control program. So this is the letter that I was referring to. I think you probably have a hard copy to look over in case you have any questions. So what are the next steps? You've evaluated the individual, the applicant. He doesn't have active TB. You determine he has latent TB infection. And you explain the benefits of treatment, and they want to take treatment. And they have health insurance. So what do you do? Well, so some of you also are primary care providers. You can certainly do and manage the treatment yourselves, and I would highly encourage you to do that. If they have health insurance, they have a reimbursement mechanism, you know, you would go ahead and bill the way that you would bill for other patients. If they have a medical home elsewhere and they prefer to go back to that medical home, then I would recommend that you refer them to the primary care doctor. And it would be helpful if you provided some documentation, because sometimes the patients don't quite understand what we're asking them to do, but if you provide documentation for the PMD to know, I had a, you know, patient has positive QFT, normal X-ray, wants to take LTBI treatment. You know, very simple, right? Three lines, that's all they need. And then once we've contacted you, we may be asking you to submit I-693 so that we can help monitor that process and try to encourage the patients to follow through with their primary care doctors. So what happens if an applicant has latent TB infection and they want treatment, but they don't have health insurance, right? So what do we do then? So in that sense, they can be referred to the public health department for LTBI treatment. So who would you refer? So basically anybody who doesn't have health insurance and any patient who doesn't have a medical home. LTBI is not an exclusion for immigration medical clearance, meaning that, you know, we can't force these people to do this. It's not a requirement, but it's, you know, it's highly recommended, right? We want to prevent TB that's going to end up killing them, you know, 20 years down the line or 10 years down the line. And how do you refer? Right now we have the same CMR form that we use for reporting TB cases and suspects. We would only ask that you also indicate any additional medical conditions that confer higher risk, including foreign birth in a high incidence country, diabetes, HIV, whatever it is that is a risk factor, you would go ahead and put it on that form. So this is the same form, right? So a lot of the information up at the top may not necessarily apply for them. For example, you would have the chest X-ray result and it would say normal, right? And then down at the bottom here, what the remarks are, you will write country of birth, medical comorbidities such as HIV, diabetes, TNF-alpha blockers, prednisone, you know, chemotherapy, something like that. And you would send that out. And the same reporting process would happen. We would receive it, we would send it, forward it to the public health center according to address of residence. The public health nurse supervisor would distribute it and prioritize, and then finally the public health nurse would get all the referrals and prioritize appointments, and we'll get that patient in. Now, if they don't have a high-risk condition, it may take them a little longer to get an appointment, but they're not supposed to turn anybody away, okay? So that's something that, we can reassure them. So the public health center will contact the patient. This is what the patient can expect, right? Somebody from the public health department will contact them, be given an appointment, and the wait time could be up to 3 months. But they will get an appointment, and then they will have an initial visit with a doctor or an extended role nurse, and they will have subsequent visits with nursing. And they will have no charges, no co-pays for the visits, and the medications are free, but because it will be covered by the Department of Public Health. Okay, and we offer all the regimens that we talked about earlier. We offer INH, 3-HP, rifampin. Right now we're really pushing for 3-HP, which is the 3 months of INH and rifapentine for the weekly therapy, because it's much shorter, and we provide directly observed therapy in the clinic. And so that seems to be a regimen that has high completion rates. If the patients don't want to come to clinic every week, because sometimes it can be a hassle, then we will recommend rifampin for 4 months. Also a shorter course, prioritizing shorter course treatments to get patients through the treatment. So what else can we do to help our applicants? Obviously, having medical coverage will be very helpful for these individuals, and provide education about how to navigate our fairly complicated health system and find a medical home, because eventually outside of this they're going to need something or other for, a broken bone or diabetes or some kind of blood pressure screening, etc. So right now in LA County we have 2 medical coverage options: My Health LA, I'm not sure if you guys have heard of that, and Covered California, which is California's version of ACA. So what is My Health LA? It's not technically medical insurance, it's medical coverage. It's a no-cost health care program for LA County residents. The only requirement is that you live in LA County and have an LA County address or a statement of homelessness. And sometimes people can provide that when they can get that from a shelter, for example. And the target is all persons who are uninsured or uninsurable, meaning we don't ask for paperwork about, status, right? So that means the undocumented are eligible for this. You do have to be an adult, however, and there are income limits. So people might say, oh, I can't afford health insurance, but if they don't meet that income requirement, then yes, they can afford health insurance under another plan. They receive services through county facilities. Primarily, they would want to establish a home through the county facilities managed by the Department of Health Services. So that's like the sister department to the Department of Public Health, right? And then they also have community partners that have clinics in the community to provide medical care. And the other option is Covered California. You guys probably are all familiar with this, which is California's version of the ACA, and it's for all persons who are lawfully present in California, and that includes immigrants who are lawfully in California. The immigration status is kept confidential, meaning that if patients apply for Covered California, it is not going to impact their ability to have their status adjustment approved. So they're not going to say, oh, well, they're asking for Covered California, they're submitting an application for Covered California, so we're not going to approve their paperwork. And they can be eligible for Medi-Cal or even discounts for private insurance. So I think this is a great option for people who don't quite make the poverty cutoffs for My Health LA, but still need some assistance. They can get some federal subsidies through this mechanism. So those who are not lawfully present may still qualify for Medi-Cal, but they need to apply to find out. And so there's a little bit of a barrier because sometimes people don't want to apply because they're afraid of the implications of that. So with that, I'd like to point you to the theme and motto for the CDC and WHO and the Stop TB partnership, which is NTB, Unite to End TB. And I think at this point we understand that we really need the collaboration of everybody to fight this disease. And this is where you can really help, because you're the front line, seeing the foreign-born, seeing the people who are at the highest risk for TB. And you're already doing half the work, which is the testing. Now we're just trying to get the second half of the of the plan done, which is referral for treatment and convince patients that it's important and get them treated. So with that, I'd like to end, and I'll take any questions. The question in the back. So the question was, you already have a partnership with County, LAC, USC, and Harvard, UCLA, is that right? Yes, so basically any licensed medical person can provide treatment for latent TB infection, right? The Department of Public Health, we're sort of like the last resort safety net, right, in order to protect public health. But these individuals who don't have health insurance, they would do very well in establishing a medical home in the county system through DHS county hospitals such as LAC, USC, or Harvard, UCLA. They would need to get in by requesting a primary care provider and then getting in through that system. So yeah, that's absolutely acceptable, and it would be great.
So far, I refer all the patients to Monroeville Health Center. Why do other community clinics accept the patients?
I'm sorry, can you repeat the question?
So far, only Monroeville Health Center accept the immigration patients. The other community clinic will not take care of them.
The public health clinics are turning people away? Is that what you're...
Yeah, there's only one accepting Monroeville Health Clinic.
Yeah, so I'm surprised to hear that, and if that's the case, it's something that we definitely need to look at. They're not supposed to turn people away. It's just that people might need to wait a long time to get an appointment. They might be turning people away who, when they talk to them, they find out that they have insurance, they have Kaiser, or they have something else, you know, because they're only really supposed to see people who don't have a medical home and don't have insurance. And right now, this year, some of the health centers are joining. And so because of they call them co-locations, so a couple of health centers are joining in one site. And because of that, perhaps it's creating a little bit of a backlog of appointments. And so maybe that's one of the reasons why people might be getting turned away, but they really shouldn't be. You know, that isn't one of the functions that we're supposed to provide is treatment.
The clinic closest to my place is El Monte Health Clinic, but they don't accept the immigration patients.
El Monte Health Clinic is not one of our public health centers.
Oh?
Monrovia is our public health center. So there are community providers out there who receive funds through the county. They're not technically run by the county. They're independent community providers. They're federally qualified health centers. So maybe that's one of the places that you're thinking of. Yeah, so our health center is Morovia, and they do take patients. Yeah, other questions? Yes, so the question was, if the patient belongs to a network like Kaiser or UCLA Health, right, would it be appropriate to refer those patients to those networks to get treatment? So if it's an active TB patient or a TB suspect, yes, but you still have to report to the TB control program because that's our function. We need to monitor all the TB cases and all the suspects. If it's a latent TB infection, it is absolutely perfect for you to refer them back to their providers. One of the goals of our partnership for TB elimination is we're going to try to establish a pilot to see how we can ensure that those patients really do go back to their primary care providers to receive LTBI treatment, right? Because you might refer them and think, oh, okay, I've done my part, I've referred them, but they're like, oh, whatever, I got my paperwork, I'm going to go home and never come back again, right? So we want to establish that system where we can check and see, okay, well, what's the barrier? Why aren't you going back to your doctor? Why, you know, is it the cost, or is it just you think it's not important? Or maybe you don't believe that you have TB infection, right? So those are some of the questions that we want to address through a pilot study, through the Partnership for TB Elimination. Yeah.
Oh, do you have a number or an email for my Health LA, or how do we?
I don't know it off the top of my head, but it is something that you can look up online. Just type in LA County My Health LA, and you will have, you know, they have a web page with referral and application process. Yeah. Question?
What was the outcome of that case you presented?
Well, so we caught that patient through an I-693 form that was sent to our office through one of our pilot sites, and we contacted, you know, we referred it to the district. They contacted him and brought that patient in for evaluation. I think the cultures are still pending, so we don't know yet if he is an active case or not. But yeah, he was plugged into the system.
So you showed us something that's not finished.
Not completely finished, but just to show you that that patient should have been referred but wasn't, as an illustration. Any other questions? Hey.